Hello, everyone, and good afternoon to those of you on the East Coast, and good morning to those of you on the West Coast. Lots of folks are joining in, so it is the top of the hour, and I wanted to go ahead and get started. And I wanted to begin by thanking you for responding to our invitation and for your attendance today. My name is Michael Ganofsky, and I'm the Director of Business Development for the HCI Group. We would like to welcome you to our webinar titled Dual Coding, Stop Gambling with Your Organization's Revenue. Out of respect for everyone's time, we would like to get started right away. And due to the large number of attendees today, your phones have been muted. Please feel free to jot down any questions or comments for further discussion, and feel free to call or email myself or Whitney Wrabel, who is our ICD-10 Service Line Director, at the information that you see on the screen. You'll see our phone numbers and our email addresses, and we will work very promptly to get back with you after this webinar. For the webinar today, as I mentioned, phones will be muted. There's many attendees all across the country, and the webinar is being recorded, and an automated copy actually will be sent out to you in follow-up, so you will have access to what you hear presented today. Again, questions and comments follow up after the webinar. I know that your time is important, so I did want to get started right away and tell you a little bit about today's presentation. The HCI Group, which is our firm, is a healthcare information technology consulting services firm. We're based in Jacksonville, Florida, and we have an international presence in countries like Canada and the UK and the Middle East. HCI's focus is on supporting clients with EHR implementations and providing support solutions well beyond implementation. At this time, please allow me to introduce our presenters today, Julie Baxter and Kathleen Egan. Julie and Kathleen each have over 15 years of healthcare leadership experience and a wide array of experience in the revenue cycle space with both providers and with payers. They are both currently assisting providers with ICD-10 needs and are elbow deep in various projects. So without further delay, please allow me to turn the microphone over to Kathleen and Julie.
Thank you so much. Hi, everybody. I'm glad that you can join us today. I'm going to start off by providing the framework for today's discussion by outlining our objectives for today's call. So we're going to start off with an ICD-10 overview, and then we're going to discuss some of the technology remediation preparedness steps for dual coding, things like system remediation activities, provider-payer collaboration, end-to-end testing preparation, and then we're going to start to discuss dual coding strategies and then evaluate the benefits of dual coding while defining a roadmap approach and also include some real-world examples. Next slide, please, Michael. So we're going to talk a little bit to start off with a background on ICD-10. As we all know, ICD-10 is the biggest change to healthcare providers since the creation of Medicare. Implementing ICD-10 will impact every IT system, process, and transaction that contains or uses a diagnosis or procedure code. It affects many aspects of business operations and technology alike. It has been reported that the devotion of time and resources will be greater than that required for Y2K. Next slide, please. ICD-10 is not simply a refinement or expansion of ICD-9. Rather, it represents a wholesale replacement of one coding system with another that is fundamentally different in terms of structure and logic. And as you can see from the slide, the image in the slide, this is really a drastic change in complexity. There's a lot changing with the move from I-9 to I-10. Next slide, please. The differences in structure and logic include several facets. First of all, the level of detail required to code is extensive, including the requirement for laterality, body part, and methodology description. Secondly, the codes need to be built based on the documentation. Memorization will be making memorization more difficult. Next slide, please. Some of the limitations that exist with the current code structure are, as you can see from the slide, outdated with limited ability to accommodate new procedures and diagnosis. And we all know that ICD-9 lacks the specificity and the detail required, and that's with some of the advantages that ICD-10 brings. We can clearly see the value because it provides us more specificity, ensuring more accurate payments for new procedures, fewer rejected claims, improved disease management, and a plethora of other benefits. Next. In preparation for ICD-10 dual coding, I'm going to begin to speak with a few areas that are critical in preparation for a successful dual coding to take place. We're going to start with talking about developing an impact assessment strategy. IT system remediation is a critical component in the successful implementation of ICD-10. It is a critical touch point in various areas of the program and end-to-end testing, dual coding, and system functionality, just to name a few. These all rely on IT system remediation as a critical success dependency. The first step in system remediation is to develop an impact assessment strategy. An assessment of the areas affected by ICD-10 is one of the team's initial activities to identify technology modifications, outreach, and education required, as well as operational process modifications to efficiently implement and configure the new code set. The assessment activities include conducting outreach and education and data collection surveys. The information collected will allow organizations to analyze areas where it is most at risk regarding the implementation. It is in the best interest of each organization to build time into the schedule for completing a detailed systems assessment for mutual understanding of all system modifications required for ICD-10 compliance. Assessment questionnaires can be done in the following ways. You can utilize email surveys, various departments, intranet web surveys, paper surveys, in-person interviews, you name it. Next slide, please. The next step is conduct a systems inventory. The recommended approach is to start by conducting an inventory of all applications and systems within the organization that process or store ICD-9 codes. The results of the systems inventory process would also be added to the assessment findings, as systems identified to be impacted by the implementation will require further analysis to determine the specific changes and level of effort required. You can then develop a heat map prioritization criticality matrix to prioritize a phased approach to remediation by criticality of your system's applications. This can also be used in much of the end-to-end testing planning. Next slide, please. The next step is develop assessment questions. A comprehensive assessment of all systems and technologies includes developing a list of questions regarding usage of ICD-10 codes and data elements. This typically involves vendors and internal subject matter experts closest to the application architecture, infrastructure, and configuration. Assessment questions will need to be compiled specifically for the following topics related to usage. Software systems currently using ICD-9 codes and planned systems for ICD-10 usage. Staff currently using ICD-9 codes and plan to use ICD-10 codes. Staff currently using data or data elements derived from ICD-9 codes and the planned usage of ICD-10 codes. Future plans for implementing and using new technology or modules within current technology that uses ICD-9 codes and that would use ICD-10 codes. Next slide, please. The next step is conduct a comprehensive systems analysis assessment. The assessment activity should start with third-party applications, as their work required to complete the assessment and required modifications is out of the direct control of your organization. If your organization employs vendors, vendor readiness is of critical importance to several tasks on the project. This includes testing and verification that will directly impact other critical project tasks. Therefore, vendor tasks automatically fall on the critical path for the scope of the project because of the potential to directly affect the three project elements: scope, time, and cost. Next slide, please. The next step is review vendor and third-party contracts. The organization should identify the appropriate resources to review vendor and third-party contracts in detail to determine if modifications are necessary to change systems or procedures required by the regulations. Some vendors may not be able to comply with the new ICD-10 code sets and will need to be replaced, thus requiring the identification, review, negotiation, and acquisition of replacement technology or service providers within the project timeline. This process can be run concurrently with the assessment activities to work towards completing all review activities and allow the most time possible to complete modification activities. Next slide, please. The next area that we're going to touch on is the provider-payer collaboration relationship. While inherently symbiotic, the provider-payer relationship nonetheless has been considered one of rivalry. At the heart of this process is provider billing and payer reimbursement. This is often a complicated and cumbersome process, as we all know. However, the impending transition to ICD-10 presents a new window of opportunity for building more cooperative relationships. The ICD-10 implementation, slated for October 2014, provides payers and providers alike with a unique chance to collaborate to mitigate the mutual risks associated with the conversion. In managing their day-to-day operations, providers and payers rely on data to support a myriad of activities. Providers capture clinical data that directs treatment decisions. Payers collect data that determines reimbursement payouts. Historically, neither side has been very proactive about sharing its data with the other. However, that silo-driven mindset is rapidly changing with the ICD-10 conversion. Next slide, please. So the next thing that I want to talk about is the importance of end-to-end testing in preparation for dual coding success. The move from ICD-9 to ICD-10 promises long-term benefits in both efficiency and accuracy, but it also poses a staggeringly complex remediation challenge. ICD-10 involves a fourfold leap in the diagnosis codes and a 22-fold leap in the procedure codes, used in every part of the clinical and business value chain. While this will eventually help improve care and drive efficiencies, the complexity and breadth of this shift requires organizations to begin remediation and testing now, in close cooperation with business stakeholders to ensure compliance by the proposed deadline. Effective ICD testing must focus not just on technical requirements, but also on business objectives, such as clinical equivalency, benefit neutrality, financial integrity, and operational stability. The test plan should take a risk-based approach to prioritizing testing most of the critical functions and scenarios. It should take into account internal constraints, such as competition for funding, as well as external constraints, such as delays in the availability of ICD-10 compliant products from vendors. Because each organization has its own mix of applications with unique dependencies and process flows, ICD-10 testing requires each healthcare payer to properly schedule its unique sequence of unit and end-to-end testing. As I spoke earlier, healthcare payers must also coordinate ICD testing with the ongoing QA of other enterprise applications. Finally, there is the challenge of creating accurate test data for an ICD-10 application environment that does not yet exist. This requires not only tools, but also an analytical approach and method that depends on human input and decision-making. So with that said, I'm now going to turn the presentation over to Kathleen Egan, who will share with you further information on dual coding preparation approach. Kathleen?
Thank you, Julie. That was a great explanation of what needs to be in place, not only for ICD-10 readiness, but as a good foundation for developing a dual coding program or process. The October 1st, 2014 deadline is quickly approaching, and we know that there are going to be impacts to our health system as well as our revenue. CMS experts are telling us that ICD-10 will initially result in a decrease in cash flow and a loss of revenue. They are also predicting that denial rates will increase by 100 to 200%, which will also cause a corresponding increase in AR days, and claims error rates will increase fivefold. So we need to be prepared for this impact. We also need to be prepared for potential delayed claim payment. One of the other things that is a huge impact to us financially is that they are suggesting that we have a reserve of 15 to 20% of our annual operating costs. So how can we mitigate some of these issues coming up before us? Part of that is a dual coding program. So as we transition into ICD-10, there are several factors that could impact our bottom line, and they are listed on that slide here. However, coder productivity is one of those areas that will significantly lead to delayed claim submission, which will result in a reduced cash flow for our organization. So how do we mitigate these impacts? We have to prepare. With proper preparation, we can avoid losses to our cash collection delays during ICD-10 implementation and beyond. As Julie has previously mentioned, accurate IT assessments and remediation plans, documentation improvement strategies, promoting collaboration, transparency, and communication with our largest payers and clearinghouses is extremely important. Managing accounts receivable assertively now to minimize those denied payments and decreased write-offs. Do we understand our current denials? Do we know those root causes? Can we address those now prior to implementation? Working all those denials to eliminate repeated occurrences will also ensure that we obtain more first-time payments. Training and problem solving through the use of end-to-end testing is really big toward dual coding. So next slide, please. I'm sorry, we're on slide 19, Michael. Some reports are estimating that coding productivity will decrease by 20 to 50%, and the level of decreased productivity is actually directly correlated to the level of preparation, practice, and testing that your organizations perform prior to the implementation date. One of the items we can talk about is if your coders have already gone ICD-10 training, how do you keep that knowledge fresh? How do you keep that knowledge forefront so they continue to understand as they move into implementation? One option is to allow the coders to dual code. And our definition today of dual coding is coding one medical record encounter, discharge or visit, in both ICD-10 and ICD-9, one after the other, that's referred to as native coding, by the same coder. Done strategically, this can serve many purposes and keep productivity close to target. You're on the current slide, Michael. Thank you. And not all health systems or organizations are alike, and challenges as well as resources vary amongst each facility. So we have to determine what are our goals with a dual coding program. And at a minimum, we need to focus our efforts on the following two areas: minimizing business disruptions and analyzing the financial impact of ICD-10. And while it's going to require more time up front for your coders to dual code, taking these measures now has the potential to improve accuracy in both saving time and money after the implementation date. So implementing a comprehensive dual coding program now will mitigate the serious risk of improper coding, denied claims, potential lost revenue, and it will also help prevent raising red flags for external audits. So creating a dual coding transition plan is key to successfully ensuring clinical documentation integrity is maintained. With dual coding, we are preparing for success with coding and billing in ICD-10. You can stay on that slide, Michael. Thank you. So as organizations move to dual coding, they must first be clear about their reasons for implementing a dual coding program. Do you know why you want to do this? What are your results going to be? How are you going to use them? And you need to do that in order to obtain a more effective dual coding program. So dual coding should be part of the training and education for your coders. It will provide them not only valuable practice during the transition date, but it will also be able to provide you some information as you move forward with the dual coding process. Dual coding can assist with reimbursement analysis. So as you go through your dual coding process, you can test your systems for ICD-10 remediation accuracy, making sure that those claims can run through all of your systems. They can go through your internal scrubbers. They can cross through your clearinghouses and to your payers. And as in ICD-10, as not in 5010, most of the payers have promised that they will test with us and send us back an 835, adjudicated 835. That's one way we can test the accuracy of our coding, and we can follow that all the way back through from financial impact, whether the DRGs are changing, whether some DRGs have become ungroupable, whether there have been DRG shifts. We can determine not only our coding accuracy, but we can go all the way back to physician documentation and show the physicians true and specific examples of their documentation and how it impacted us in our revenue or reimbursement. We can also use dual coding to implement a CDI program or improve our CDI program. We can talk about the documentation problems followed by physician training. Documentation policies and data capture templates can be improved. We can make changes to our current workflows. And a critical path in any ICD-10 project is the successful and timely flow of data both internally through all your impacted systems and externally through your trading partners. Next slide, please. There are several different options that you can use to do your dual coding process. One of those is simultaneous coding by one coder. This is where each coder takes a chart in I-9 and then codes it in I-10, and this has been determined to be the most efficient way and is a good choice when your goal of dual coding includes reasonable volume as well as practice for the coder. So the second one is simultaneous coding by two coders. One coder codes in I-9 and the other coder codes the same chart in I-10. This is good if you are considering contract coding staff before, during, and after your transition, and this method will help you assess the need for additional resources by measuring the difference in the amount of time it will take to code. Inter-rater reliability coding is interesting as this takes several coders coding the same chart, and that is followed by a roundtable or an educational session to discuss the differences in code selection. And this is a good method if your project target is just education-based. And of course, you have contract coding, and there are several options for that. You can have your coders code in I-10 while your contract coders are coding in I-9, or any combination. Some of the questions that you need to think about before choosing your methodology are: what are your biggest concerns? What are your documentation challenges? We all know that's going to be a big issue for us. What types of cases at your facility are most impacted by ICD-10? If you don't have time to do a dual coding program with every chart that comes in, which is unreasonable, you might want to determine what is your highest impact in revenue, volume, and risk, and target those in dual coding as well as your documentation improvement programs. And what feedback do you plan to provide from the results of this dual coding? How will you define your sample? And what coding method that we talked about previously is best for your organization? Next slide, please. So some reports are estimating that coding productivity will decrease by 20 to 50%. I believe that the level of decreased productivity is going to be directly correlated to your level of preparation, practice, and testing. If your coders have undergone training, we need to move forward with a dual coding process. And we can look at this strategically as we move forward. Next slide, please. So there's a large system in the Pacific Northwest that we are working with that has already begun dual coding. It's an 884-bed system with 7 hospitals and over 200 physician clinics, and they have already trained over 200 staff in ICD-10. This staff included coders as well as anybody that uses codified data such as charge capture specialists, CDI specialists, clinical research analysts, anybody that uses codified data in their day-to-day work. They began testing a year ago on paper with one of their largest payers, and that gave us some good information on our coding accuracy even before we went to ICD-10 training. With the coders trained now, what we needed to determine was how to keep that knowledge from being lost, and we began the dual coding program where, to keep productivity loss at a minimum now, each coder codes 2 cases per day in both ICD-9 and ICD-10. And currently those coders are selecting those cases with some oversight of the coding leads and supervisors, but as we get further down the road, they will be selected based on a financial impact analysis that was done, determining their highest risk, highest revenue, and highest volume cases. Next slide, please. So there are several benefits to implementing a dual coding program. It not only provides practice to your coders, it provides assistance with end-to-end testing. It determines and helps determine your financial impact analysis, tracking new payer denials and rejections, measuring your coding accuracy, and measuring your documentation specificity. So it's good to invest that time now to code in both I-9 and I-10, and that will expose any points of confusion your coders are having. It will allow you to develop a strategy and address the issue head-on. Dual coding will also enable HIM management teams to evaluate how their education and training programs are working and determine what additional resources and tools their coders might need to be successful in the transition. And now I will turn it back over to Michael.
Wonderful. Thank you very much, Kathleen and Julie, for your time today. In closing, we would like to thank everyone on the line for their time today. As we stated earlier, we are actively engaged in a number of ICD-10 projects across the country. If you need any further assistance with dual coding and specifically the topic at hand today, or anything in a broader area to do with ICD-10 in general, please, again, feel free to reach out to Whitney or myself at the contact information that you see here on this slide. Once again, thank you, and we hope that you all have a wonderful rest of your day. Thank you.